My name is Scott Fawcett. I'm an orthopedic surgeon with the Centers for Advanced Orthopedics and at Sibley Memorial Hospital. I also serve as the president of the CAO Research Foundation, team physician for the United States Ski and Snowboard team, pool physician team. I also serve as one of the team physicians for GW Athletics in Zion College High School, and I also run the hip preservation program at George Washington Hospital. It's my honor to be here with you all this evening to talk about meniscus injuries. I want to take a moment to thank the Joseph and Alma Gildenhorn Institute for Bone and Joint Health for sponsoring this evening's session and for all of their support for everything we do at Sibley Memorial Hospital. I also want to thank Kathy for coordinating and organizing, putting all the effort in for this evening's session. A few housekeeping items. On the taskbar with your Zoom account, you will see a section for Q&A. Please feel free to put any questions you may have in there at any point. As I get towards the end of the presentation, I will go through these one by one and answer them for you live. And also we'll have further information towards the end if you wish to have a consultation. Unfortunately, over this platform, I will not be able to provide direct patient advice or care specific to your case. We can talk about the generalities of meniscus injuries and their treatment. So without further ado, we'll move ahead and begin the talk. A lot has been written in the recent lay news regarding meniscus tears. New York Times wrote an article talking that common knee surgery does very little for some. Another article showing that why useless surgery is still popular. But my goal for you this evening is to address that these types of surgeries are not the only way to address meniscus tears, and there are other ways to help preserve and restore meniscus function and preserve the knee other than meniscectomy. So don't just consider everything you read in the news to be the gospel for medicine. My goal for this evening's talk is to talk about meniscus injuries, give you an update on our understanding of what the meniscus anatomy is and its function. I want to talk about how meniscus tears occur, address what are the symptoms of meniscus tear and how may they differ from knee osteoarthritis or other knee conditions. Lastly, what treatment options are available, and what if there's arthritis and a meniscus tear? What is a patient to do? What is the meniscus? So the meniscus is a tough fibrous tissue that sits between the bones and the knee joint of the femur and the tibia. So you can see here on this image right here, this is the shin bone or the tibia bone, and on the top of it lays this cartilage right here. Here's a top-down view right here. And the meniscus is this triangular and circular shaped structure that sits on both the inner or medial and lateral tibial plateau. It attaches to 2 points in the center of the tibia plateau right here, and it functions to provide conformity of the rounded edge of the femur joint to the flat of the top of the shin bone. So here's what it also covers a lot of the gliding cartilage or articular cartilage of the tibia bone here, more than 50% on the lateral side and about 50% on the medial side. It has these attachments, which are called the roots, as well as other ligaments that attach it to various aspects around the knee and the femur. Also, the meniscus moves. So it's not a static structure. And you can see here in this anatomic model of moving the knee back and forth, the meniscus, particularly on the lateral outer side, has a lot of mobility. So it's important to account for it. The function of the meniscus is to provide the rounded or convex shape of the femur to the concave and flat shape of the tibia. So in the lateral tibia, it's actually convex on convex. And so we provide this lateral meniscus, which sits right here and provides distribution of the forces of gravity and load to the joint evenly, so we don't have point contact, as we would here. When the meniscus is torn, we get point contact on the articular cartilage, and that increases the stress on the cartilage and increases the risk of osteoarthritis. What is a meniscus tear? So the meniscus, it can be torn in different types of shapes and directions. In this case right here, this is a longitudinal tear. So it goes up and down along the shape of the meniscus. This is called a radial tear, where it's dividing the meniscus into two pieces. A horizontal tear divides it in this direction where you have two flaps sitting on top of each other. Oblique tear is a radial tear that then also has a longitudinal component. And then the bucket handle tear is a very long and deep longitudinal tear that the remaining meniscus tissue flips over like the handle of a bucket. The function of the meniscus provides, as we talked about, the distribution of forces. And to do that, it has a number of fibers, of collagen fibers that run along the inside of the meniscus. The circumferential fibers attach from root to root, and they resist the stresses to push the meniscus out away from the knee joint. And then it has these radial fibers that go back and forth and wrap around the circumferential fibers. And then it has some random fibers that tie everything together. There are some cells in there, and also there are blood vessels that come from the periphery, or the outer portion of the knee joint, into the meniscus tissue and feed it with nutrients and take away wastes. In the deeper areas of these, there are not very large blood vessels, but there are a lot of healing cells, which we call mesenchymal cells or stem cells. And then the root tear is when the meniscus actually tears off of the bone. They call that a meniscus root tear. It's the most dreaded tear. And that's because it functions as almost taking the meniscus out, because all of its function has been obliterated by the root tear. And this is a study in which they had a normal knee, and then they created a root tear, and they could see the forces. And there are a lot greater forces when you had the root tear, or if you took out the whole meniscus, very similar forces in very very low contact area when you take that out. And then when you repaired it, the root tear, you put it back where it belonged, you restored the normal forces and contact area of the knee. Another study looking at the results of these tears and what happens when they get bigger, and we get increased stress over the cartilage, which is the gliding cartilage that allows our knee to glide smoothly and without pain. How can the meniscus be injured? The two most common types are degenerative and traumatic type. Degenerative type means wear and tear, age-related. And over time, this meniscus tissue, just like the rest of the collagen or other parts of our body, degenerates. It becomes very frail and can tear easily with normal forces. And we can see this here in this type of tear. This tissue can be very beat up. It doesn't have a nice smooth features to it, the smooth and clean features that normal meniscus tissue would have. Compared to this, we have nice smooth features of the meniscus. And the traumatic type, which are associated with injuries. The most common type of injury is the ACL. And we're going to see a very high frequency of meniscus injuries with ACL injuries. And that's because when the ACL tears, the two bones shift on each other, and it tears the meniscus, sliding it back over the tibia, and then that's tears. So this is a type of bucket handle tear right here, where the meniscus has been torn off of where it should be attached, a longitudinal type. What are the symptoms of a meniscus tear? Most commonly, we have joint line pain. So if you feel along the knee where the hinge is, and you palpate along there, it's very tender, and most commonly towards the back of the knee. It's easiest to do this with a knee and a little bit of flexion, and you can palpate around the knee and feel whether there's pain along the meniscus portion of the knee. In unstable tears or tears where the meniscus is moving quite a bit, patients will often describe a catching sensation where the meniscus is flipping in and out, causing problems like that. Pain is very common with kneeling, with meniscus tears, and that's because you're pushing the tibia bone up and the femur bone is sliding down, and that's putting a lot of shear force on the meniscus. So it's very common to have kneeling pain with meniscus tears. And in the acute setting, you may develop some knee stiffness just because of the injury of the knee, and the body's a bit wanting to kind of prevent a lot of motion in the knee. So you may develop some knee stiffness either from swelling or just from protection of the knee joint. And you may also have swelling in the acute setting of the knee injury, where the knee may become the size of a grapefruit. It can be very painful and stiff. How do we diagnose a meniscus tear? In medicine, we talk about the history. So that's what you would describe, and the events leading up to the pain and injury. So oftentimes, meniscus injuries will start happening after some specific activity. The more traumatic tears, obviously a traumatic activity, but even some of the degenerative tears, particularly the root tears, have a specific time point that the patient recollects. June 28th, got off the bus and I felt a pop in my knee, and ever since then, my knee has been killing me. And so that's what we call by the pain history or injury history, and then the symptoms as we described above. It's very helpful to delineate whether or not someone may have a meniscus tear. But also we want to put our hands on, and we want to feel and do an exam of the knee, and we want to palpate along the back of the knee. Sometimes pain with hyperflexion, bringing the knee all the way back, can cause some pain. A McMurray's test is a specific test in which we manipulate the knee that can put stress on the meniscus and reproduce pain. And then patients may have an effusion in their knee, maybe swollen. Those are all signs of meniscus injury or tear. Some of the radiographic or X-ray imaging that we want to do is mostly to rule out osteoarthritis. We can't see a meniscus tear on an X-ray because X-rays only look at the bones. And so we want to make sure that the knee looks like this, where we have a nice space between the femur and the tibia bone, and the meniscus would live in this spot. If we see the meniscus, that's usually a case of what's called chondrocalcinosis, and that's a sign of a chronic injury. But in this case, this is severe osteoarthritis. The meniscus has been extruded or pushed out of the way. There's no room for the meniscus here, or it's been previously removed in a meniscectomy or meniscal removal surgery. We already see these bone spurs coming off here. So this is knee osteoarthritis. This is a condition that may have a meniscus tear, but the meniscus tear at this point has become a non sequitur because the major driver of pain, disability, is the knee osteoarthritis. We also want to check the alignment and make sure that someone's not too bow-legged or knock-kneed, because that can put excessive pressure in the knee, also a sign of osteoarthritis, and that may play a role in what surgical options need to be addressed with if we were to operate on the meniscus tear. All right. On the MRI, we can see very good detail of the meniscus tissue and the remaining the cartilage in the knee, as well as the muscles and ligaments and tendons in the knee joint. We've already seen the x-rays that show the bones, and here we can see good gliding cartilage on the femur and tibia, but the meniscus has been injured, and we can see that because of what's called a ghost sign. The meniscus is this structure right here and right here, and in the back, it's absent. The white represents fluid, and the meniscus has been torn and pulled off of the knee joint. This is a meniscus root tear. The meniscus is also being pushed out. It shouldn't be this far out from the knee. And in some cases, we can even see it torn here, where this is the meniscus tear and it's being pushed out to the side. And this is a relatively severe meniscus tear. It's flipped up here. It's absent now, this lateral side over here. That's a very significant meniscus tear. We can also diagnose this with in-office arthroscopy. So we can take a small camera. It's with a needle, just like this, and it has this very small camera off the end of it. We put a little local anesthetic, just so that if you go to the dentist, you can put that camera right in the knee here in our clinic, and we can diagnose these meniscus root tears, like we see here, or cartilage tear. It doesn't provide any pain. It's not very painful at all. And you can see here's a tablet, the screen, we can see everything. And we put the camera in here, and we can be able to see all the cartilage. We can diagnose osteoarthritis, meniscus tear, ligament injuries, and other types of injuries inside the knee joint. It's not very good for looking at the bones or the ligaments outside the knee joint. So for that, we always rely on MRI. How are we going to treat these meniscus tears? I would say the most common treatment for meniscus tears is non-surgical treatment. You can address most meniscus tears with physical therapy. They're relatively small. They don't disrupt the functionality of the knee joint. In many cases, meniscus can heal itself in 6 weeks. Physical therapy is used to address knee motion and strength, to restore that, and get rid of that stiffness, and make sure that any type of compensation that a patient may have taken because of the pain or injury of the knee, that we restore that normal mechanics of the knee. In some cases, we may recommend activity modification. So we may say, let's not run those half marathons or marathons. Let's kind of talk about running shorter distances. let's avoid some of the deep positions in yoga and maybe reconsider the yoga practice to avoid some of those risky positions. Cortisone injection is very helpful for decreasing inflammation in the knee joint acutely. It's not a great strategy to treat any knee problem on a regular basis with cortisone, but it's very effective and has had a very long-lasting, long history of its use. But we don't know exactly all of its side effects and risks, and so it can be helpful. It's probably very low risk for 1 or 2 or 3 shots, but it's not something you want to keep getting every few weeks. Platelet-rich plasma is an investigational procedure which has not shown tremendous promise for meniscus tears, but has been done in a lot of cases and has had some anecdotal evidence providing improvement in patients' knee function and pain. Platelet-rich plasma we'll go into later, but that's basically where you take people's blood, spin it down, get the healing factors that allow our body to heal injuries, concentrate them, and place them into the knee joint. Specifically try and target that meniscus area, meniscus tear. What is a meniscectomy? So the surgical procedures that have been commonly used for meniscus tears, the most common is called a meniscectomy, and that's where the torn portion is trimmed back. The downside of this is that all that meniscal function that was there is decreased and never will come back because we've cut out all that meniscus tissue. And this carries an increased risk of knee osteoarthritis with it. Not everyone will get a knee osteoarthritis, but a significant amount of portions of people who have had meniscectomy have a higher risk of knee arthritis. And this is what, a tear here like this, go and resect all this out. If you resected all of this meniscus out, then the risk of that is that it could develop. Now we don't have that meniscus tissue, and now the cartilage is going to be bone. Start wearing away and end up being bone on bone. So it's a very limited time that I would actually recommend doing a procedure like that. But in some cases, for some patients, it may be the right procedure. They may not be willing to do the rehabilitation. They may need to have this may be their only option, or it may not be repairable. My preference in almost every meniscus tear case that I'm going to take to the operating for surgery is to repair it, because we can restore that function in the knee and eliminate the risk of or reduce the risk of osteoarthritis to what the normal level of arthritis would be. And so in that case, we want to bring the knee and we're going to sew the meniscus back to where it belongs using stitches or other devices. And in some cases where patients have had the meniscus removed because of meniscectomy and they still have pain in their knee, that's pretty common. It's called post-meniscectomy pain syndrome. We can actually transplant meniscal tissue or a meniscal implant and restore that meniscus. Now, the important point here is that if you've developed arthritis because of the meniscus being removed, putting in a new meniscus is not going to restore the arthritis. So you may have a fancy new collagen meniscal implant, but horrible knee arthritis, and your knee function and pain will not change. So when we're talking about arthritis, we're going to talk more about partial and total knee replacement options when we do surgery, not restoring meniscus and degenerative cartilage procedures. And this is where we take an allograft, where we take someone else's, so a donated meniscus, someone who's passed away, has a nice, fresh, good-looking meniscus. We'll transplant that into place into someone who is missing part or all their meniscus. Save the meniscus is the motto. We want to save the meniscus because we can really reduce the risk of our osteoarthritis. This is looking at a case in which all of these meniscus tears healed. It's very high rate of meniscus healing, a complete healing in over 73% of patients, incomplete healing in 18% of patients, and only 9% of patients failed. And we restored all of the mean pressures in the knee and made their knee back to normal. So there's a 70% increase in rates of knee osteoarthritis within 10 years with meniscectomy compared to meniscus repair. So in every case, we want to try and restore the meniscal tissue, keep what's there, repair it back, rehabilitate the knee. So some of the repair techniques that we do, there are various different kinds. When it's close to the root, we're going to repair it back to the bone. When it's way here in the back of the meniscus, we'll do a technique either called inside out or all inside, which is where we either pass sutures around the meniscus using just the small arthroscopic portal or keyhole, or we may use it to pass needles out the back of the knee and then make a small incision in the back of the knee and sew those stitches to the back of the knee to sew that meniscus back. It all depends on how much tissue we have back here to sew on. And then over here, we'll do another technique called outside in, which we pass the stitches from outside the knee into the knee joint and then back out. This is an outside in repair here. And so we have the small keyhole surgery, and we're able to take these, we have the camera in there, and the needle is going into the meniscus, and we can pass the stitches back and forth, and then we'll make a small incision in the knee and be able to repair that meniscus back to the capsule of the knee. Okay, that's outside in. The all inside technique is where we would take tissue here. We prepare the meniscus, make sure we get any sort of scar tissue out between the meniscus, and then we use a device that will pass the suture inside the knee joint. This is the all inside technique, and this is a pretty innovative procedure. This tool has been around for about 5 years. I've been using it very frequently, and allows to have excellent outcomes, incredible healing. We've already published 2 studies. We're recruiting patients now to another study on the use of this device to repair meniscus tears and show how well patients do afterwards. So this is called the NovaStitch tool, and that's what we use to do all inside repairs of the meniscus. The stability of the meniscus repair is paramount, right? If you just put one stitch in, right, you wouldn't just put one nail in your house. You put multiple nails all over your house to hold everything together. So we have to do the same thing when we repair meniscus. And then the inside out is when we pass needles from inside the knee to outside the knee and use through a small incision in the back, be able to capture those needles. The root repair technique is an innovative technique in which I repair the meniscus root by first putting stitches into the, I'm gonna go back to that. Putting stitches into the meniscus and then bring them down through a hole in the tibia. So we reattach that meniscus back to where it belongs. Okay, so here we're preparing the end of the bone to accept the torn portion of the meniscus. Sometimes we have to make sure that the meniscus is fully mobilized and can move. And we're going to drill those tunnels that are going to go from the shin bone up to into the knee joint. So these 2 tunnels here. And then we pass the sutures that are going to go through the meniscus here. And those are the sutures that they're going to stay in the knee joint. These are not absorbable sutures. They're going to hold that meniscus in place. And it's going to bring that meniscus back into place and secure it there. Then through a few weeks of healing, they'll heal down, and then we'll rehabilitate the knee, get it strong, get the knee working again, and have incredible results with the knee. So our meniscus repair, our clinical outcomes show very good rates of healing. So don't let doctors tell you that meniscus don't heal, because meniscus heals. You just have to repair it properly, and you have to get a lot of suture in there, and you got to rehabilitate it properly, and you also have to do it in the right knee. Right? So it may not say it didn't heal because there was a lot of arthritis. Well, that's because there was arthritis, not because the meniscus didn't heal. Meniscus will heal if we get adequate fixation and we are able to respectively rehabilitate the knee. And rehabilitation is significant, and this is where most people rather choose to have meniscectomy and take their chances with the osteoarthritis, because it's talking about 6 weeks of being on crutches to allow the meniscus tear to heal itself back. And then we will do progressive range of motion and then strengthening, and you won't be back to full activity for almost 5 to 6 months after surgery. So it's definitely an investment in your knee, and it may not be right for some. Some people are just not able to maintain the precautions in terms of limited weight bearing. They have balance issues or strength issues, and some people just are not willing to undergo that amount of physical therapy. But the big question is always before anything is you may see that meniscus tear on your MRI report, but the more important information is what is the status of the articular cartilage? Because the meniscus tear may have yielded osteoarthritis, but then repairing the meniscus is not going to restore the articular cartilage. So if you have osteoarthritis, we have a bunch of tools to help manage that problem. We don't have any tools that have really shown reliable cures for osteoarthritis. And those tools to manage it include anti-inflammatory medications, such as over-the-counter, Aleve, Advil, and sometimes prescription medications, such as you might have heard of Mobic or Meloxicam, Voltaren, Celebrex. Those are all over-the-counter. Those are all prescription-strength anti-inflammatories. Physical therapy, as I mentioned, can help work on range of motion, stabilizing the knee, make sure the knee is balanced in terms of its strength. Bracing is very helpful to help manage unicompartmental knee arthritis, so just arthritis in just one portion of the knee. Using a brace can help unload that area of arthritis and lessen pain and improve function. And injection treatments, such as we already described, the PRP, cortisone, and viscosupplementations, such as hyaluronic acid and other injection types. There's a number on the market. And then lastly, when all of those tools in our tool bag has failed, partial or total knee replacement is an option. So in summary, meniscus injuries are common. They can occur with an injury or on their own. The treatment for these includes non-operative treatment to surgically repair this tear, but that's dependent on the severity of the pain and the disability that this meniscus tear is creating. Also, if there's any underlying arthritis, it's not a candidate for meniscus repair, and in my opinion, even meniscectomy. And then the meniscus tear type and severity plays a role in whether or not to proceed with surgery or continue with non-operative treatment. And lastly, don't be afraid of meniscus repair. It has an excellent outcome and can slow the progression of future knee osteoarthritis. Well, I want to go back to a lot has been in the news regarding meniscus tears, but we are changing that paradigm. We had an article published in the Washington Post last year about a patient who highlighted her recovery after a meniscus root tear and was able to get back to running. We also had a Washington NBC4 News segment talking about this tear as well. And I want to thank everyone for their time and their participation. If you're interested in getting an evaluation or a consultation with me, please take down this information. This is my website. There's a place to go to a link to set up an appointment. You can also call our office and schedule an appointment. And then if you'd rather email, you can email appointments@scottbostonmd.com, and that will go to my staff, and they'll get back in touch with you to schedule an appointment. So thank you to the Gildenhorn Institute for this evening, and now I'd like to address the questions. So feel free to put any questions and answers. We have a lot of time to address them, and I'll spend all the time we can to go over them. The first question is, what should I do if I already had a torn meniscus flap removed 18 months ago? Well, I think the first question about that is, if you're continue to having pain, then it's probably worthwhile to get an evaluation either with your surgeon or with myself. If the tear has been big enough and you're still having pain in the knee and disability, then you may be a candidate for a meniscus transplant. If you're not having pain and you're just curious how to prevent future knee arthritis, oftentimes that unloader bracing that I talked about, particularly when you're doing high impact activities, can be helpful to slow the progression of osteoarthritis. And you just want to monitor your knee. Again, not everybody's going to get knee osteoarthritis, but if you're starting to have symptoms or pain or things like that, bring that attention to me, and we can help figure out what's the right solution for your knee. Our next question is there a strategy related to poking holes in the bones as part of the surgery? So I believe you're discussing a strategy called microfracture, and this is actually something we do all the time. And it originally was invented by my mentor, Dr. Richard Stedman, as a tool to help grow back scar cartilage. Scar cartilage is the articular cartilage or the gliding cartilage. And unfortunately, a lot of people had to use the same name for meniscus. and it's a different tissue that provides a different function. So it's really important to get out of the habit of saying, oh, I tore cartilage, meaning the meniscus. We should use the proper term, I tore my meniscus, because torn cartilage is a lot more difficult to fix. We have some strategies. One is to regrow this scar cartilage through this microfracture technique. Another technique is to transplant either your own cartilage from another area of the knee joint or donated cartilage that we put in place in that area. And that's a separate topic to discuss at another point. But in regards to meniscus, we do perform this type of procedure where we go up into the knee, not where the articular cartilage is, but in other areas of the knee joint to place small holes to allow the healing cells, our stem cells that live inside of our bones, to come out of that area and find their way to the area of the meniscus tear. And they'll find that area of injury and exposed collagen and begin to heal the meniscus. And we've done some studies because when we do other surgery, like ACL surgery, where we do drill tunnels in the bone to do the ACL ligament surgery, we found earlier on much higher rates of healing of the meniscus. Whereas if we had the same injury and we would do the meniscus first, and then we would come back, or we would do the ACL first, and then we would come back and do the meniscus, we didn't have as good healing rates with that meniscus surgery. And so we've now done some studies comparing ACL with meniscus repairs compared to isolated meniscus tears with this bone drilling technique, and we show equal outcomes. So it's a very good technique to help with a biologic augmentation to help improve our healing rates of meniscus tears. Have you seen any results from stem cell injections? Unfortunately, no. Everyone's very excited to do stem cell injections. I think there is a ton of hype, and unfortunately, I think there's a lot of false advertising about what stem cells are doing. You know, we are working day and night in all of our laboratories trying to find a way to heal cartilage injuries, to heal meniscus injuries, and we're using the top-notch stem cells with some of the best scientists. And you know, we've seen a lot of anecdotal evidence, meaning patients have had it and spent tens of thousands of dollars in stem cell injection, and they feel better. But unfortunately, there's very little evidence to actually prove that new cartilage has been formed or the meniscus healed. And part of that is because we have to provide stability to these tears. If the meniscus is this far apart in a tear, we inject stem cells, it's not going to grow tissue to grow this together. We have to get that together and sew that together, and then we can talk about stem cells. But I don't think we need to spend tens of thousands of dollars in our clinics doing stem cell therapy at this point, when we have no way to target those stem cells to the chronic tear of the meniscus, and we have no way to provide stability to those tears. So if you're interested in doing it and you want to take a risk and you're willing to spend the money, I think it's very low risk in this setting to do meniscus tears. But in terms of the most cost-effective technique, it's been shown in multiple studies that meniscus repair over meniscectomy is a much more cost-effective method to manage meniscus tears than stem cell treatments. How long do injections last, and how often can you have them? How many can you have? Like I mentioned, there's a number of injections, so I'll try and briefly address each one of them. When we talk about cortisone injections, this is an injection of medication that's synthetically made, and its role is basically to shut down inflammation. It communicates to the cells inside the knee joint and tells it to stop the inflammatory process. And it does it in a much more aggressive manner than some of our other targeted medications. And we don't know exactly all of the details about how it does that. But we do think in some studies that, you know, just doing willy-nilly injections over and over, that patients may develop arthritis a little faster in those cohorts than in patients who have not had as frequent cortisone injections. There's a lot of problems with that study because nobody was randomized to receive injections regardless of their knee pain or not. This is all observational studies, and these patients clearly wouldn't be just having injections for no reason. They often have pain or more advanced arthritis, and when the knee feels better, they're going to go back and do activities. And so that may be the cause of progressive knee osteoarthritis. But in general, most physicians recommend waiting at least 3 months between getting cortisone injections. And when you're talking about injections in the knee, they're there's not a lot of data to support the absolute number of injections in the knee. But if they're losing their effectiveness and they only last for a week or a few days, then it's really kind of pointless to keep doing them. So then you may want to consider other options. A caveat is cortisone injections into tendons for other tendon problems, which is not the discussion. You want to really avoid doing a lot of injections of those because that has been shown to cause increased rates of tendon rupture, particularly in the feet and ankle and in the hip area and also in the shoulder. So we don't want to be just putting cortisone. We want to be doing it for a really specific purpose, understand what that purpose is, and using it sparingly. Other injections such as viscosupplementation, which come with names like Euflexa, Gelson, Synvisc, Hymovic, Orthovisc, those are all hyaluronic acid derivatives. And that is unfortunately given the name of gel shots, lubricants. It's not really lubricating the knee. It's not providing any support to the knee. Hyaluronic acid is a very common substance in knee joint fluid. And when it interacts with the lining of the knee joint, it also, in a much more targeted fashion, decreases inflammation process in the knee joint, thereby stabilizing further cartilage degeneration. Those have been studied, and in that study, they looked at patients showing 6 months of improvement. And all the insurance companies just grasped onto that, and they said, we will provide this every 6 months as a benefit. But there's really no studies saying the safety of doing it more frequently. It's a relatively benign injection. Some people have reactions to that, just like any substance. Some people may have allergic reaction. But in regards to being paid for by insurance, 6 months is how often you can get them. And then lastly, PRP, which in more recent studies have looked at combined, and this is for osteoarthritis and meniscus tears, combined PRP and viscosupplementation, hyaluronic acid and PRP together, has shown synergistic, meaning better than each one improvement. And that's done through a series of 2 PRP injections and 3 viscosupplementation injections for a total of 3 injections. We can combine them together. And those have shown improved outcomes over a year. The study stopped tracking people at a year, so we don't really know how long that has been going on. That's a protocol I've been using now for 18 months, and we haven't had to redo those injections for the patients that are successful. Not everyone is successful in any of these injections, and that's important to understand when you undergo any treatment is, what's the likelihood of success and what are the options if it doesn't succeed. And in those cases, that may be just too advanced osteoarthritis, then probably needs to have either a loading brace or a surgical approach. Thank you all for these questions. I have one more here. Feel free to add any more. We got plenty of time. So this patient's reporting that they had surgery last October on their left knee, and now they've become bow-legged on the left. Is it possible to get it straightened again by physical therapy, or is this permanent? And unfortunately, in broad issues, when we've removed a large portion of the meniscus, we can actually start to get the knee to start collapsing. And once it's hit a point, it's called like a tipping point. Once you've hit that point, then more force is created on the knee, which creates more deformity, which creates more force, which creates more deformity, which creates more force. And it can get actually extremely bad. In some of these underserved areas in the United States and throughout the world, we can see incredible deformities of patients who have just waited and waited and waited. To fix this, I would recommend initially starting to go with an unloader brace to help get the knee out straight. And if it's been recently done, just a year ago, it's possible that we can restore that. Its ability to get the knee out straight with a brace. Physical therapy is unlikely to provide enough stability for that problem. Some people have tried orthotics, different orthotics to level out the knee. We got to be careful with that because we don't want to start messing up the ankle joint or the hip joint if we need to put in a large orthotic to address deformity. Surgical approach, it depends. If we have a lot of arthritis, you may be beneficial just having a partial knee replacement or total knee replacement. If you don't have a lot of arthritis, you could be a candidate for a meniscus transplant. And if you're that much bow-legged, you may need what's called an osteotomy or a bone correction procedure to corrective alignment as well to help improve the outcomes of that meniscus surgery and prevent further injury. Some patients just undergo an osteotomy, but a lot of the data published by my colleagues in Mayo Clinic have shown that partial knee replacement is a much easier to recover than an osteotomy. It's probably easier. But in patients who don't have, who have normal cartilage, we don't want to rush off to a partial knee replacement. Well, that's the last of the questions that have been provided to me. Again, I want to thank all of the attendees for your time and your interest. I also want to thank the Gildenhorn Institute for sponsoring this evening's session, as well as Sibley and Johns Hopkins Hospital. And I also want to thank Kathy for your support in getting this set up for everybody. And again, please feel free, if you have any further questions, feel free to send me an email. You can go on my website, learn more about meniscus tears and meniscus repairs, as well as osteoarthritis of the knee. And if you have some further questions, you can always reach out to us by phone and make an appointment. Thank you again. I wish you all a very safe and pleasant evening. And with that, we will adjourn this evening's webinar.